Good afternoon, everybody, and thank you so much for joining us for another one of our Meet the Specialist sessions. These short sessions are a great way to introduce our specialists, our new ones and the ones who've been with us for a while, to our clients so you can see what they're really like. And today we are joined by the very, very lovely Dr. Matt Hislop, who is a sports and exercise physician. So without further ado, I will hand over to you, Doctor, and you can tell us a little bit about you, about what you do, and about where your specialty falls in relation to the medico-legal space. Thank you so much.
Right. Thanks, Michelle. Thanks, everyone, for having me today. So I was asked to give a bit of a brief rundown of what got me into sports medicine and how I wound up where I am. Before I started medicine, I did a year of human movement studies. And that probably started a lifelong love of exercise science, exercise physiology, and eventually sports medicine. I wound up going on and studying medicine and graduated from UQ in 1997, and then spent a couple of years working in Southeast Queensland at the PA Hospital and the Nambour General Hospital on the sunny coast, which I really enjoyed too. After my formative years, I had the opportunity to go to Ireland for a year, and I did a master's degree in anatomy and looked particularly at chronic exertional compartment syndrome of the lower limb. One of the good things about that was I was able to become a world expert in that particular field, and that's an area of cross-referral between myself and orthopaedic surgeons in particular. So when I returned from Ireland, I started my specialty training in sports medicine. I spent 2 years in Brisbane, where at the time I was the only registrar in all of Queensland studying sports med. And then I moved to Melbourne, where I found a lot of like-minded individuals, you know, being the sporting capital of Australia and certainly at the forefront of sport and exercise medicine. I made a lot of important contacts and friends down there and gained a new understanding of how to manage different conditions. I finally got my fellowship, well, not finally, it took me 4 years, in 2005 and returned to Brisbane. The intention was always to return to Brisbane. And I've been working in private practice since. I opened my own standalone clinic in Hawthorn on Brisbane southside in 2010, and we've been here. We're a multi-disciplinary clinic. We've got a number of sports medicine physicians and registrars. We've got allied health, and we're lucky enough to have a number of visiting specialists come to the clinic too. In terms of teams and people I've worked with over the years, I've had the privilege of working with a number of elite national and international teams. I'm currently at Brisbane Broncos Chief Medical Officer and have been doing that for about 11 years now. I also look after the Queensland State of Origin Rugby League team since 2016. I look after the Brisbane International Tennis and have been doing that since 2012. Lucky enough to go to the London Olympics in 2012 with kayak and canoeing. And this year I'll be going as part of medical headquarters to the Paris 2024 Olympics. So part of that, you know, allows you to be able to work collaboratively with a team and understanding particularly, you know, the multiple different steps of injury and rehab and getting someone back to full function. I'm a certified medical examiner and I'm the only sports physician on the Queensland IME specialist panel. So I know a number of people would actually say, what is a sports physician? What do you actually do? We are a relatively new speciality. The way I explain to it, my job is to help people that are struggling with either an acute or overuse musculoskeletal condition or a medical condition that is stopping them maintain a fit and active lifestyle, including returning to work. So we specialise particularly in diagnosis, in interpretation of radiology, and then rehabilitation and getting people back to work. It's not just MSK injuries. We were chatting before we started recording about concussion management, which we're very heavily involved in. other conditions, osteoporosis, bone health, diabetes, asthma. However, we are predominantly extensively trained in musculoskeletal medicine. And I guess what would distinguish us from other specialities, perhaps, rheumatologists and some other more medically aligned colleagues, is that we are trained particularly in joint examination. So, we're there at the forefront. We can examine these joints. We can determine the acute injuries, overuse injuries, and really help in the diagnosis. In private practice, I work very closely, particularly with allied health and physiotherapy, and we will bounce back off each other quite a lot. And in doing so, I understand rehabilitation, what's appropriate rehabilitation, what's an appropriate recovery from an injury, and when an injury might be taking longer than perhaps it should be to recover. We work very closely with our orthopedic cousins, and I like to think our relationship analogous to a cardiothoracic surgeon and a cardiologist. We certainly don't manage the surgical side of things. We manage the non-operative MSK injuries, but we also know when it's appropriate to involve orthopedic surgeons and get surgery as the definitive treatment. So how would a sports physician be of benefit in medico-legal reporting? I guess I think we are the perfect consultant to use in a case where a non-surgical management is required. As I say, we excel in diagnosis. We're able to determine what is wrong with the patient, confirm clinical findings, and independently look at radiology and not be relying on reports from the radiologists. Some examples of conditions that we manage would be osteoarthritis of any joint, shoulder bursitis, impingement, frozen shoulders, spine, neck, mid-back, low back pain, radiculopathy, hip pain, particularly lateral hip pain with gluteal tendinopathy, trochanteric bursitis, patellofemoral knee pain, exertional leg pain is my area of special interest, ankle and foot injuries, particularly ligament sprains and injuries there. All right, so that's a bit of a mouthful, but that's me in a nutshell.
It's actually a lot more than I thought your specialty encompassed, and that really interests me, particularly what you were saying in relation to pain. So I take it that these are people who've already sustained an injury and possibly have had a surgery or something, but they've got the chronic pain, ongoing pain, or is this pain that can be managed or what's the word, cured?
Oh, look, pain is a very complex area and certainly multifactorial in cause, diagnosis and management. Having said that, I do see a number of patients that have progressed to surgery and wind up significantly worse. And it's not that the surgery has been at fault, it's that they've developed either a neuropathic pain syndrome or, at worst case, a complex regional pain syndrome.
Wow. Yeah. And
the important thing to realize there is that often further, particularly surgical interventions, are not going to help, even though, the clinicians are desperate to help the patient. You need quite a complex approach to treating those patients.
Wow, absolutely. I recently read a book by one of our other specialists, pardon me, and it's called, what is it? Hypocrisy. And it's about how in Australian medicine, the first do no harm concept has resulted in a paradox where specialists are doing surgeries and interventions to far more quickly than they used for fear of the patient simply going somewhere else and getting it done, or for fear of being accused of not providing the appropriate or required service. And I guess that's what you're talking about there, is people, having a treatment that turns out not to bring the desired result, and then they've got to manage ongoing symptoms.
Yeah, certainly I think in the past there has been some inappropriate surgery performed.
Yeah, absolutely.
we're not even talking about that. We're talking about surgery that might have been appropriate, but the initial condition of a neuropathic pain syndrome was perhaps missed, and the patient does not get the desired outcome from the surgery.
Wow. If any of the people who have joined us today, if you have a question that you would like to ask, you can unmute yourself and fire away with your question.
Good to meet you, Dr. Hislop. Can I check, noting what you've spoken about in terms of your profession, if you ever have cases where you've given independent medical advice come to tribunal hearing or appeal, do you typically find your medical evidence is viewed in the eyes of those appeal bodies with the same strength as, say, an OCFIS or an ortho?
I haven't had that come where I've had a clash of opinions a lot in the past, but I certainly can justify my training and knowledge and expertise. Certainly, if it was a case of a hip replacement that went wrong, I don't think my opinion would trump an orthopedic surgeon familiar with doing that sort of operation. However, if it's management of recalcitrant lateral epicondylosis, I'd say I probably know more than, in my opinion, would be worth more than many other specialties.
Yeah.
Thank you so much.
That would be something that we certainly are noticing in the medico-legal field, a trend towards going to other specialists who manage the post-surgical or post-injury condition, and that's actually gaining real credence in the field. Often, for example, orthopedic surgeons are concerned with, was this a textbook surgery? Is the scar good? How does it look like to me now? But they're really not thinking about 5 years down the track. And that's where somebody, like, as you mentioned, an OCFIS or a sports physician really comes in absolutely handy. Anyone else have a question that they would like to ask? No? Okay, I have got one question from somebody who was not able to attend today. And they wanted to know how is a determination made to get somebody, particularly an athlete or a person who has a particularly physical job, what is the risk of getting them back to movement too soon? And can that cause further injury? Or is it better to get people back moving soon?
That's a very good question, actually. And that helps me touch on the concept of the industrial athlete, where an injured worker is not too different to an athlete trying to get back to full function. Key is an initial diagnosis. And certainly there are some conditions that require immobilization for a period, particularly when there's fractures or significant bone contusion or osteochondral defects. Having said that, the bulk of soft tissue injuries and ligamentous injuries, having the patient immobilized for a prolonged period of time is more harmful than good. So the focus in rehabilitation has shifted from one of prolonged immobilization to early movement, work on particular areas such as proprioception, flexibility, strength, but provide the patient with pain relief and strategies to deal with any transient flares of pain.
Wow.
The patients who rehabilitate will get better more quickly and more completely than those that just hope for it to happen.
Wow. Thank you so much. If no one else has any questions? No? Look, this has been actually really, really interesting, really informative. I thank you so much for your time today. This recording will come out to everyone who registered sometime this afternoon, I hope, and it will be available on our YouTube channel for everyone to watch. And for those who have a login to our Mag Connect booking platform, you can also find it on the left-hand side on the menu tab under Educational Seminars. We thank you again for your time. Have a great rest of the day.
Thanks for having me. Thank you, everyone.
Stop that recording.